very important disease, and a very common disease rather. Uh, you may come across the people around you, maybe sometimes you find family members, they are complaining of epigastric pain. So how we will going to differentiate, or we will be able to differentiate between a peptic ulcer symptoms from a simple uh, acid reflux disease, or cholelithiasis, or cholelithiasis, or a pancreatitis. These are the few differentials which can be kept in mind while discussing this acid peptic disease. So first of all, we will going to discuss the anatomy, the brief anatomy of the stomach and the duodenum. The stomach is a J-shaped stomach. It has two surfaces, anterior and posterior, two curvatures, greater and lesser, two orifices, the cardia and pylorus, and it has fundus, body, and the pyloric antrum. Functions of the stomach is digestion of the food, reduce the acid food, and acts as a reservoir, and it absorbs the vitamin B12, iron, and calcium. A stimulant of the gastric secretions are the gastrin, which act on the parietal cells and releases the hydrochloric acid. Acetylcholine, a vagus stimulus, by the help of vagus stimulus, it acts on the gastric cells and increases the acid secretions. Histamine, the mast cells, and the parietal and the chief cells. These are the we're going to see how it differs. Like suppose as regard to the histamine, what are the type of the medicine which acts on the histamine to decrease the acid peptic disease, and what is the function of gastrin, where we will going to perform the, in which type of the cases of the acid peptic disease we will going to perform the gastrin secretory test, which is not commonly being performed in, and we're going to see in the middle of the lecture what are the conditions where in which we're going to perform this gastrin test. Histology, it has serous, muscular, submucous, and mucus from outside to inside. In the duodenum, we see that it has first part, second part, third part, and the fourth part. There are four parts of the duodenum, and as we know, the second part, it has the opening of the common bile duct, common with the pancreatic duct, as in ample of water, and there is a sphincter of Oddi there. The commonly the peptic ulcer, the duodenal ulcer occurs in the first part of the duodenum. In the rest of the part, it is not common. In the duodenum, or in the entropyloric junction, commonly the peptic ulcer presents. However, in the gastric, it may be found anywhere in the stomach, and commonly in the distal stomach, pylorus, and the prepyloric region, the common presentation of the peptic ulcers are there. Blood supply, it is supplied by the left gastric artery, right gastric artery, right gastroepiploic, left gastroepiploic, and the short gastric arteries. These are the common blood supplies, and this should be kept in mind. Pathogenesis, 4 etiological factors are responsible for the vast majority of the peptic ulcer disease, and we can see that Helicobacter pylori infection. This is the commonest type of the infections, which is associated with 90 to 95% of the duodenal ulcer, and 70 to 90% of the gastric ulcers. So, considering in mind that much the association of Helicobacter pylori in both the diseases, both the type of the ulcer like duodenal and gastric. However, in the gastric it has more frequent association as compared to the gastric, but nevertheless the gastric ulcer is also having 70 to 90% association of the Helicobacter pylori. Non-steroidal anti-inflammatory drugs, yes, it has a proven role. So the people, those who are on non-steroidal anti-inflammatory drugs, they are prone to develop the peptic ulcer disease. There is 8-fold increase in the risk of the duodenal ulcer and 40-fold increase in the risk of the gastric ulcer, and has dose dependent relationship. Dose dependent, what is dose dependent relationship? Once you stop those medication, the disease will not progress, but whatever the damage it has done to the mucosa, that would be there, that should need the treatment for the healing of that mucosal ulcers. However, the disease cannot be progressed, or will not going to progress once you stop taking this non-steroidal anti-inflammatory drugs. All analgesias, most of the analgesias has the adverse effects on the gastric mucosa, but especially the non-steroidal anti-inflammatory, it has 8-fold increase of the duodenal and the 40-fold increase in the gastric ulcer. Other drugs like steroids, they also has the association in the pathogenesis of the peptic ulcer disease. Cigarette smoking, it has a strong association, so one must keep in mind that that once you wanted to treat the once you wanted to treat this ulcer, the causative agents should be minimized or stopped. So the cigarette smoking should be stopped. Acid hypersecretion, this is the cause. So any things, any agents, any drugs, any additives like cigarette smoking which increases the acid hypersecretion should be stopped. Presentation. What are the presentations? As we know, the commonest presentation of the peptic ulcer disease is pain in the epigastric region. So once the patient comes to you with the pain in the epigastric region, you need to find out first whether this is a pain of a peptic ulcer or it is other than the peptic ulcer. Suppose your patient is giving a pain in the epigastric or little bit more on the right side, and the patient is at the age of 40, and she is more commonly the female, and it is fertile, and she is fertile and obese, and the pain is radiating to the right shoulder, so you can able to differentiate that this is not a peptic ulcer disease, this is an gallbladder disease. So suppose your patient is giving a pain which is at the epigastrium, but it is severe in intensity, it is increased on lying down and relieved by bending forward. So this is not an acid peptic disease, but this is a pain which is of pancreatitis. If the patient is having a pain and the pain is associated with jaundice, so this is not an acid peptic disease pain, but this is a hepatitis, or tenderness on the right side is there, so this could be an pain of a viral hepatitis, fulminant hepatitis, rather than acid peptic disease. So these are the few commonest differentials which on the basis of which you can able to differentiate between the common acid peptic disease and the other differentials. Now, how the acid peptic disease, if suppose the patient is coming to you with a pain in the epigastrium, how would we be able to differentiate between the pain of a gastric ulcer from a pain of a duodenal ulcer? Yes, suppose the patient is giving a pain which is increased by taking meal, okay, and it is relieved by after the 2 hours of the meal, like once the food is passed from the stomach to the duodenum, the patient gets relief. Or if the patient is having a vomiting, the vomiting relieves the pain. So this pain is a gastric ulcer, typical gastric ulcer pain. Or if the patient is having a gnawing or intermittent pain which is burning in nature, obviously in both the cases, duodenal and gastric, that pain would be burning, gnawing and intermittent. But in gastric it is increased by taking meal, relieved after 2 hours of the meal. Very much contrastly, the pain of the duodenal ulcer is relieved. Yes, it is not only by taking meal it is relieved. On empty stomach it is increases. Yes, so typical of the early morning pain, like patients wake up 2 a.m. or 3 a.m. in the morning by an empty stomach, and once the patient take some meal, milk or anything, the pain gets relief. So in the duodenal ulcer the pain is relieved by taking meal, however in the gastric ulcer it is increased by taking meal. Now the vomiting will be more in the cases of the duodenal ulcer, less in the, like 40% of the cases there will be vomiting in the gastric ulcer, and in the 60% of the cases the pain will be in the duodenal ulcer. Obviously the vomiting relieves the pain in the case of the gastric ulcer, however it is increased by the vomiting. As we know, the empty stomach pain is the pain of a duodenal ulcer, however the pain is relieved by taking meal. So in the vomiting, once the vomiting occurs, the pain is relieved in the cases of the gastric ulcer, however by the vomiting the pain gets increased in the duodenal ulcer. Alteration in the weight. Yes, pain is altered. Yes, there would be no change, or there will be more weight of gain in the weight gain in the cases of duodenal ulcer, because patient wants to take the meal. Patient wants to take meal more and more in order to take the relief of the pain. So there will be more because of the eating, there will be weight gain. However, in the cases of gastric ulcer there will be decrease, there will be weight loss, or there might not be no weight loss. So no increase in the weight. Bleeding, more commonly with the duodenal ulcer, and hematemesis, which is the acute bleeding, fresh bleeding. Bleeding could be occult, which can be picked in the stool examination, or it could be fresh, acute, as in hematemesis. In both the cases the duodenal ulcer bleeds more, so there will be more bleeding in the cases of duodenal ulcer as compared to the gastric. In the examination you won't be able to find any finding, no obvious sign, unless there is a complication, like if duodenal or gastric ulcer gets has the pyloric obstruction, gastric outlet obstruction, because of the benign stricture at the duodenum, first part of the duodenum, or in the stomach, the patient might be having a fullness in the epigastrium, or there might be a tenderness, mild tenderness, or there could be a succussion splash, which is the commonest physical sign which could be elicited in the cases where the patient is having a gastric outlet obstruction. Diagnosis. Yes, the diagnosis of the peptic ulcer is based on clinical history more. There are less examination findings in the in this case, but as we have discussed, as a complication, we might get a succussion splash. So, as I am always emphasizing that most of our diagnosis is most of the time based on the clinical examination. So once you diagnose your patient on clinical examination, your diagnosis is almost always, or 99% of the time, or 95% of the time is correct. You need certain investigation in order to find out or to confirm the diagnosis. Yes, so the best is you can perform the along with the baseline investigation, because in the CBC sometimes you find decrease in the hemoglobin in both the cases because of the bleeding and because of the intake food is less in the gastric. However, in the duodenum, the intake of the food is normal or more, but because of the bleeding, your patient of peptic ulcer disease might be having a decreased hemoglobin. Other findings, other investigations are baseline investigations are almost normal, except if there is severe vomiting, the patient might be having an electrolyte imbalance. Barium studies. As I told you in the earlier lecture as well, that barium meal is considered for barium meal is done for the studies or to detect the disease pathology in the stomach. However, barium is swallow is for the esophagus. Barium small bowel studies is for the small bowel diseases, to detect the small bowel diseases, or barium large bowel studies are, or barium large bowel enema is for the large bowel disease detection. However, the barium meal studies for the stomach, so here we will obviously going to perform the barium meal, and in that case we will find a crater of the stomach ulcer, gastric ulcer, or the duodenal ulcer. You might find some you can say irregularity in the mucosa of the stomach and the duodenum, or the crater in there. So by that you can able to diagnose the barium. By barium you can diagnose the peptic ulcer. However, the upper GI endoscopy is the gold standard. Why? Because that can able to diagnose the both the peptic ulcer, both gastric and the duodenum. As well, we can able to take the biopsy from the stomach, because in long standing cases or as a baseline we wanted to know the status of the of that ulcer, because in long standing cases you might get the malignancy in the gastric ulcers. However, in the duodenal ulcer there are rare chances of development of the gastric in the gastric ulcer, the development of malignancy. Detection of H. pylori infection. Yes, urea breath test, serology antibody testing, and enteral biopsy for histopathology, or rapid urease test using the cod liver oil testing, CLO testing, is one of the ways to find out the H. pylori infections. The commonest type of this H. pylori infection which we are doing nowadays is the serological antibody testing. So by that serological antibodies against the H. pylori we can detect, and we can if those IgM antibodies we find in a patient, we can label that patient as an infected case of the H. pylori, and those patients need the eradication therapy. Fasting gastrin levels. This is performed in the cases where we find that the patient is having multiple ulcers, or ulcer at the unusual site, or the patient is not being able to be treated by the regular medication for the acid peptic disease. So in those cases we can suspect the patient is having a Zollinger-Ellison syndrome, where in the Zollinger-Ellison syndrome the patient is having ulcers anywhere in the stomach, multiple ulcers, or in the small intestine as well. So in those cases we can get the increased level of the serum gastrin. Treatment. How you are going to treat these cases? Okay, so in the treatment, the first step in the treatment is the modification of the patient's lifestyle. This is the first step. Rather than embarking upon the medical treatment, one has to change his lifestyle. Suppose the patient is not doing regular exercise, he must advise to go for the regular exercise. If the patient is taking or habitual of or addicted to smoking, he should quit smoking, because particularly the cessation of smoking is the hallmark in the treatment of the acid peptic disease. So this should be stopped. If the person is not going to stop this smoking, whether you are treating with the H2 blockers or with the proton pump inhibitor, your patient might go into a problem, and those patients are taken as an intractable to the medical therapy. Intractability. So those patients might end up with the surgical management of the acid peptic disease rather than the medical therapy, as 99 or 95% of our patients can get the benefit of the medical treatment. So they don't need nowadays the surgical treatment. We're going to discuss this later in the time. That yes, what are the medical treatment? In the medical treatment, we have the commonest from like 1960. The H2 blockers came into the market, and that were being used. So after that, the surgical treatment is almost abundant. Like surgical treatment for the acid peptic disease is not done since 1960 because of the availability of the H2 blockers. And as we have discussed, it work on the histamine receptors. So these H2 blockers are necessary for the treatment of the acid peptic disease. And as we know, the cause of 90 to 95% of the cases of the duodenal ulcer and 70 to 90% of our gastric ulcer, the infection of H. pylori is there. So we need to treat the patient with H. pylori. So the H. pylori eradication therapy is the cornerstone of the medical therapy. Okay? So the regime which consists of the acid reducing medication are the PPI, H2 blockers, or sometimes in a patient you might add the bismuth salicylate as well, combined with 2 antibiotic which could be from the erythrocycline group, or it could be amoxicillin. So these two antibiotics should also be added along with the PPI, H2 blockers, and bismuth salicylates for 10 to 14 days. This triple therapy is most of the time is almost 85 to 95% effective in eradicating the H. pylori. As we know, there is an association of NSAIDs in the peptic ulcer disease, though one must stop using the NSAIDs. So the person who are on NSAIDs or steroids, they should stop taking the NSAIDs. Proton pump inhibitor. The proton pump inhibitor has got a very good effective role in the treatment of the healing of the peptic ulcer, and nowadays it has got a cornerstone in the management of the peptic ulcer. So peptic ulcer disease being treated by nowadays almost 95% of the time we are using this proton pump inhibitor rather than the H2 blocker, because H2 blocker has got certain side effects which are being taken up by the proton pump inhibitor because it has less side effects than the H2 blockers. As we are a surgeon, so we are going to discuss the main treatment or the indication of the surgeries in the peptic ulcer disease. As I told you that till 1960, major portion of the surgical a major portion of the patient being treated by the surgical treatment or by the change in the lifestyle, because at that time there were the H2 blockers were not available. But now, as the H2 blocker and recently this proton pump inhibitor availability has changed this surgical therapy for the peptic ulcer disease, and now only the indication of the surgical therapy is the bleeding or a perforation or a obstruction, as I told you, as a gastric outlet obstruction because of the increased fibrosis at the pylorus and the first part of the duodenum, which leads to the constriction, complete constriction of the stomach at the pylorus, and that lead to the gastric dilatation and the gastric outlet obstruction. So that need to be treated surgically, and obviously as we know, in the gastric ulcer there is chances of the development of the malignancy. If malignancy is there, one need to remove the stomach, that part which is being involved by the cancer. As we know, this gastric ulcer has the tendency for the development of the malignancy. So especially the upper GI endoscopy, once we have performed and we have diagnosed a case of a gastric ulcer, the patient need to have the series of endoscopies for a lifetime. Yes, one has to do or undergo by the upper GI endoscopy and the biopsy in order to find out the change in the epithelium. Suppose the change of epithelium is to the metaplasia, which is changed now. So once the metaplasia is there and dysplasia comes in, so that dysplasia should be taken as a carcinoma in situ, and the patient should be treated by the surgery, not by the medical therapy. So the therapy should be stopped and the patient should undergo a surgery. One of my friend or a senior, he was a very good friend of mine. He was from SMC, Sindh Medical College, my college, and He was having the acid peptic disease. He was a very good surgeon. He worked in army, and he got retirement, and he was a major there, and he got early retirement, and he wanted to go abroad for the further studies. He has done the FCPS, and but he was having acid peptic disease, and or the gastric ulcer, and he was having a he has done the endoscopies, and one of his endoscopies, the dysplasia came, but he ignored that, as most of these patients has the denial effect. So he denied that I don't have this dysplasia, or he went to another doctor and performed an endoscopy there, and he gave the results as you don't have the dysplasia. But unfortunately, his disease progressed, and he developed a signet ring cell mucinous carcinoma, and he died of cancer. So why I am always discussing him here, because in the lectures, because anyone who is having the acid peptic symptoms in their relatives, in their nearby, or their friends, they should do an endoscopy. If suppose the duodenal ulcer is there, so no harm is there, and if the gastric ulcer is there, he has to undergo a regular series of endoscopies. So if the malignancy is there, one has to go for the treatment of that. Failure of medical therapy, I told you, if that is there, one can do the or the treatment is, or failure is there, or the intractability is there, one should do the surgery. Or in the case where you won't able to be differentiate between a malignancy or a benign disease, which sometimes there in the gastric outlet obstruction, once the complete obstruction is there, and you can get the biopsy, but you can't find the deeper portion of the biopsy to get the exact idea whether the patient is having a malignancy or not. In those cases, you need to do the surgical treatment. The procedures which being performed for the duodenal ulcer are the truncal vagotomy with pyloroplasty, truncal vagotomy with entractomy, and Billroth 1 procedure. Billroth 1 procedure is the procedure in which we do the partial gastrectomy. The distal stomach is removed, and it is anastomosed with the duodenum. Once the duodenum is anastomosed with the proximal stomach, that is called the Billroth 1 gastroduodenostomy or Billroth 1 procedure. Sorry, the next one is the Billroth 2 procedure, which is gastrojejunectomy. It is not Billroth 1, mistakenly it was written there. So the Billroth 2 procedure is the procedure in which the distal stomach is cut, resected, the duodenum kept there, around 30 centimeter or 40 centimeter distal to the DJ junction, the jejunum is cut. The distal jejunum, the proximal jejunum is taken up to the proximal stomach, and this proximal jejunum which is cut is again anastomosed with the jejunum. This is called Roux-en-Y jejunostomy. Roux-en-Y jejunostomy. So it's not duodenostomy. You are not going to anastomose with the duodenum. You are doing the Billroth 2 procedure, in which we are doing the gastrojejunostomy or Billroth 2 gastrojejunostomy. Okay? And this is called Roux-en-Y procedure as well. And another procedure which is a highly selective vagotomy, in which the not the whole of the vagus is cuffed, only the distal supply of the vagus, which is supplying the branch which is supplying the pylorus area, is cut, which is called highly selective vagotomy. Highly selective vagotomy. Here you can see the diagrammatic picture of the Billroth 1 procedure, where we can cut the stomach. You can see here the discolored area. The pink area is the normal area, and the disease area is the light brownish area, and that is being cut, and you have now left with the duodenum, the first part, and the stomach. So you can anastomose the stomach with the first part directly, or you can anastomose the stomach with the jejunum. Okay? On the fourth part of the duodenum. So this is Billroth 1. Here is the diagrammatic picture of the Billroth 2, and here you can easily see the gastrojejunostomy. Okay, you cut from the area which is shown. Okay, and here the total gastrectomy is being done, and Roux-en-Y esophagojejunostomy is done. That is done for the carcinoma of the stomach cases, where the proximal area of the tumor is there. If we cut the distal portion, as in the case we have seen here, like if this area is this light brown color area is, or light yellow color area is disease or having a malignancy, so we will not cut the whole stomach. We will cut this distal portion, and we will stitch the duodenal area, the first part of the duodenum, and we are going to anastomose the distal stomach with the jejunum as an Roux-en-Y, like this Roux-en-Y. So rather than removing the whole stomach, the half portion of the stomach is cut, and that proximal portion is being anastomosed with the jejunum, making this type of the Y. As this is seen, the proximal portion of the jejunum is having the jejunal anastomose, and the proximal portion of the jejunum is being anastomosed with the proximal portion of the stomach. In the gastric ulcer, we can do the wedge resection, intractomy with inclusion of the ulcer depending on the ulcer location, and as we have discussed, Billroth 1 and Billroth 2, especially the Billroth 2 operations, are being done for the gastric ulcer, because gastric ulcer has the tendency for the development of the malignancy. So in those cases, we need to do the complete Roux-en-Y jejunostomy. So in the acid peptic disease, what we have seen, that we have discussed that it should be differentiate. First, one should be able to differentiate the acid peptic disease from the biliary disease, from the pancreatic disease, from the jaundice or viral hepatitis, and it should be differentiated from the biliary colic. Once you have diagnosed a case of the acid peptic disease, Now the first thing is to establish whether the patient is having a gastric ulcer disease or a duodenal ulcer disease. We have a very typical history of gastric ulcer. The pain in all the cases would be gnawing, sharp, and intermittent, but the gastric ulcer pain would be more by taking meal. However, in the duodenal ulcer, the pain is relieved by taking meal. Okay, so the patient will take more and more food in the cases of the duodenal ulcer. However, patient would be afraid to eat in the cases of gastric ulcer. So obviously, once the patient is afraid of taking meal, the patient will be having a weight loss or no weight gain in the cases of gastric ulcer. However, the patient might get obese or little change or little increase in the weight in the cases of the duodenal ulcer, because patient loved to eat. He wanted to eat more and more, and most of the time frequent meal, smaller meal he takes, and he take more and more meals. The patient has more pain in the empty stomach, so the duodenal ulcer patient has a typical early morning pain like 2 a.m. in the morning or 3 a.m. in the morning, 4 a.m. in the morning. Patient wake up by the empty stomach and he takes some meal, and by taking that meal the pain gets relieved, and again he lie down and sleep. There will be more bleeding in the duodenal ulcer, less in the gastric. However, the vomiting relieves the pain in the gastric ulcer. However, the vomiting gets increase pain in the duodenal ulcer. There will be more bleeding in the cases of duodenal ulcer. There will be less bleeding in the gastric ulcer. So these are the few differentiating points on the history. Clinical examination, as we have discussed, unless the complication is there, we don't find any finding in the physical examination. However, the succussion splash or the tenderness is there once there is a gastric outlet obstruction because of the benign structure of the duodenal, first part of the duodenum, and the pylorus is there. For the diagnosis, the gold standard is the obviously endoscopy, upper GI endoscopy, and it has the advantage that we can able to take the biopsy as well, especially in the cases of gastric ulcer, because the gastric ulcer has the tendency for the development of the malignancy. So we can take the biopsies. Multiple biopsies could be taken, 8 from the different sides, in order to find out the exact nature of that mucosa. Suppose there is dysplasia or metaplasia is there, one should be having, or one should keep in mind that the patient has now the changes the epithelium from metaplasia to dysplasia, so the patient is now having a carcinoma. It's not the simple gastric ulcer, so one has to undergo for the gastrectomy, partial or total gastrectomy, depending on the cancer area. Suppose the proximal area of the stomach is with the ulcer is there, and that turn out to be an malignancy, so one need to do the total gastrectomy. If suppose distal, the commoner area is there, so one can do the partial gastrectomy. Nowadays the surgical treatment, the medical treatment is again with the H2 blockers and the PPIs, and as we know, these are PPI has got a less side effect, and nowadays very popular in medical therapy of PPI is there. However, H2 blockers since 1960 to about around 1990, people were having, or the 80s, people were having only the option of the availability of the H2 blockers. However, few of the you can say mucosal defective healing. Medications were also available like sucralfate and these type of the things which can also prevent the ulcer complication, or you can say ulcer relief of pain. Non-steroidal anti-inflammatory and the smoking has got a very strong association, so these should be stopped and lifestyle should be changed in the therapy. If suppose the patient is having a complication, bleeding is there, malignancy development, so the surgery like Billroth 2 or Billroth 1 could be performed, and the nowadays the surgical treatment has got a very limited role in the peptic ulcer disease, but that could be done in the cases once you find some complication, bleeding, malignancy, perforation. Or briefly, the perforation patient, if comes to you, it is an emergency. If suppose a patient develop a perforation, you can diagnose this patient as an peritonitis, or the patient will be having a severe pain, the pain is increased, patient might be having a vomiting, patient might have a decreased blood pressure, increased temperature and tachycardia and board-like rigidity. If all is there, obviously you are going to perform the x-rays. The plain x-ray of the chest and abdomen can delineate the presence of the free gas under the diaphragm, the both domes of the diaphragm. If that is there, your diagnosis of the peptic ulcer perforation is there. And obviously on the basis of history you can differentiate whether the gastric is there or duodenal is there. But whatever the duodenal or peptic, if suppose the gas under the diaphragm is there, one need to undergo for surgical treatment, and that is, and after the resuscitation you have to perform the repair of the ulcer perforation. If suppose gastric is there, you need to take the biopsy as well because of the importance of malignancy. If duodenum is there, there is no need to take biopsy unless you wanted to ensure that your patient might be having might not be having a H. pylori present. So in that case you can take the mucosa of the duodenum and you can send that, or the antrum you can send for that for the biopsy for the presence of H. pylori. And you have to repair the gastric or the duodenal ulcer, and that repair is by the non-absorbable sutures, and for the stomach you need to do the momental patch as well, or this momental patch should be applied for the duodenum but not for the gastric, and then you need to close the abdomen, and this is the treatment for the perforated gastric ulcer perforation.